Dr. Alexandra Phan is at the Methodist Cancer Center in Houston. She received her medical school training at the University of California, Irvine, and she tells us she's nervous, but she doesn't look very nervous. And Dr. Phan is going to talk about a drug that I'm sure you're all interested in, a new way to control diarrhea in NETs.
Thank you. Thank you. First and foremost, I'd just like to acknowledge the fact it's fantastic how many times over every year, every time I go to a patient conference, patients are 100% faithful until the last moment. If you go to a physician conference, by this time they're checking out or in the pool or somewhere else. But in any case, I am very grateful for the audience and the attention. Second, I'd like to thank the organizing committee for this association to invite me to be here to share some of my knowledge with you all. And second, I want to be acknowledging the most important group of people that motivate me and inspire me to wake up every morning and do what I do, my patient and all of you guys. Your participation on clinical trials is the reason why we have many more agents than in 2011 approved for neuroendocrine tumors. So give yourself a hand, it's because of you. Okay, so reportedly I'm not nervous, but I'm actually very nervous. No, actually I'm not. My biggest goal is trying to figure out how to deliver a talk on diarrhea around the time of lunch. So I actually changed the topic a little bit and be a little bit more broad range, but don't worry, I won't bore you the rest of the 30 minutes, okay? So I want to talk about therapeutic option in carcinoid syndrome, and I want to narrow it down to the carcinoid syndrome, particularly diarrhea, okay? But I think it's important to review by this time all of what you heard about yesterday and this morning, all those therapeutic modality. We talked about how it can control cancer, what therapy is going to go out there and hopefully at some point cure cancer. But this idea of trying to control symptoms is the reason I'm giving you guys this talk. So a lot of these topics will be reviewed. So it's a test to see if you have become an expert in NET treatment or not, okay? Actually, there is a pop quiz after this. If you don't pass, you can't leave this room. You have to stay here. So these are my learning objectives. My goals is to go review some of the concept of clinical symptoms and presentation of neuroendocrine tumor. Without knowing that, you don't know what is the goal of management of symptoms are. And then we'll talk about various category of neuroendocrine tumor that is functional, and then we're going to focus specifically carcinoid syndrome or symptoms of carcinoid syndrome, and then management, both frontline therapy and then management on refractory. That's the key. And then I'll give you my takeaway recommendation or takeaway thoughts, which is about 2 cents worth. So no, it's not that expensive, okay? So clinical presentation of neuroendocrine tumor. Neuroendocrine tumor or carcinoid tumor of the midgut, that's neuroendocrine tumor, it's all in the name. By this time you know what the difference is, but constitutional symptoms are generalized symptoms such as, such as fever, weight loss, night sweat, and loss of appetite. All of those are what we call constitutional or systemic symptoms that is usually associated with a very advanced disease or a very bulky disease or a disease such as a very high grade or fast-growing neuroendocrine tumor. Then there's a whole other sets of symptoms. These symptoms are what we call relating to the bulkiness of the disease, the location of disease. So if you have liver that is infiltrated with tumor, the liver is going to grow larger. Therefore, you're going to have symptoms consistent with a larger liver, enlarged liver, such as abdominal fullness. You get hungry getting full very quickly after very small meals. Or you just have let's say you have a mass near or around your colon or your intestine, so you have GI bleeding. So these are what we call symptoms relating to the tumor location. And then lastly is the area that we're going to talk about, symptoms relating to the hormones that is being over-secreted by the tumors. These are called symptoms of functional neuroendocrine tumor. What are functional neuroendocrine tumor? Functional neuroendocrine tumors are just tumors or neuroendocrine tumors that produce symptoms that you can attribute to hormones that you can measure, okay? So that's what it means. In my mind, the way I distribute functional neuroendocrine tumors are into very easy category. Carcinoid syndrome with its variants, both classical and the variant, and then the pancreatical duodenal neuroendocrine tumors syndrome. Just as a reminder, what the other group is about. These pancreatical duodenal neuroendocrine tumor syndrome, by the way, I made that up, so Dr. Warner here is like, what the heck, I've never heard of this pancreatical neuroendocrine. Essentially, they come from the pancreas or the duodenum, and they can produce very specific symptoms as a result of very specific oversecretion of hormones. For example, insulinoma is a neuroendocrine tumor that oversecretes insulin. So patient will present with symptoms relating to too much insulin. The blood sugars is low or other symptoms. Glucagonoma is the opposite. Patient will have symptoms relating to oversecretion of glucagon. So these are the group of functional neuroendocrine tumor that I will not concentrate on because they have association of a very specific hormone. What I like to focus on is carcinoid syndrome, both classical and variant. I chose here the classical carcinoid syndrome and the atypical or the broncho-variant carcinoid syndrome. What does that mean? What are these carcinoid syndrome? Let's talk about the classical carcinoid syndrome. Classical carcinoid syndrome is usually associated with neuroendocrine tumor that come from the midgut, the small intestine, okay? And they're usually, by the time they have these symptoms, patients usually have advanced disease or metastatic disease already because they have to have that liver metabolism to have caused these symptoms. The other thing is that it's due to the overproduction of serotonin, which can be measured by its metabolites in the urine and sometimes even in the blood, okay? Now, the variant, the symptoms or the picture of classical carcinoid syndrome are this. It's actually much more complicated than this, but it's simplified down to this. They are predominantly flushing. 80% of the classical carcinoid syndrome consists of flushing, cutaneous flushing. Diarrhea is 70% of the time. Symptoms of right-sided valvular heart disease, that means the heart is not working so well, so you have some symptoms relating to it, is either easily fatigued or you have some congestion somewhere of the liver. Whatever it is, it's symptoms relating to the right side of the heart failing because the valve has been fibrotic. And then the symptoms of bronchial constriction, the bronchial tree or the breathing pipe or the oxygen exchange system is constricted, so therefore you can have wheezing, okay? So that picture right there is a picture of a cutaneous flushing, and then the cartoon is a picture of a right-sided heart fibrosis, and you can see that inside, I don't know if there's an arrow, but inside this is the valve being fibrotic. So this valve normally should close, and so you can deliver blood or exchange blood, but if this valve becomes incompetent, then you have a problem with your heart not working well and oxygen is not exchanged, okay? So let's talk about a variant of carcinoid syndrome. It is the bronchial variant, which means that it is associated with neuroendocrine tumor that originate from the lung or respiratory system, okay? These symptoms are pretty similar to carcinoid syndrome, but they are usually more severe and lasting longer. And they can occur, these carcinoid syndrome associated with lung variant, can occur in the presence of no metastasis. So they can have just the primary and no metastasis, and they can have symptoms. Sometimes you can measure them by measuring the metabolism of the serotonin. But other times, these symptoms or these symptoms of patient that has lung carcinoid or lung neuroendocrine tumor are associated with a completely ectopic hormone being produced, such as ACTH or something else, okay? Together, the symptoms of atypical carcinoid of the lung, originating from the lung, are those. Like I said, cutaneous flushing are more severe, lasting longer, and oftentimes associated with systemic symptoms. People will have anxiety, tachycardia, and they even have disorientation as well. Diarrhea is another component of it, but there are some peculiar symptoms of this variant that is not seen in a classical carcinoid syndrome, which is edema and parasympathetic symptoms of tearing and salivations, and of course hypotension and tachycardia, which is fast heart rates and low blood pressures, okay? So these two groups are what I group together as carcinoid syndrome. And the reason is the symptoms that predominate in these two, in carcinoid syndrome, are predominantly mediated by serotonin. Okay? This is a hormone that mediates most of these symptoms, as you can see here. And that's important when we talk about management. Okay? When we talk about management of carcinoid syndrome, we're going to talk about frontline therapy and then management of the refractory symptom. That's actually the most interesting part, but let's give you a full picture. Frontline therapy of carcinoid syndrome is actually with somatostatin analogs, okay? Somatostatin is actually endogenous somatostatin, meaning normal producing somatostatin is actually a 14 amino acid, 14 little amino acid protein or peptide that inhibits the secretion of many hormones. So you can see there it's not a serotonin kind of thing, but it actually inhibits the secretion of multiple hormones that can produce the symptoms that you have in carcinoid syndrome. The available analog of somatostatin is Octreotide and Lanreotide. They work, these peptide that is synthesized as therapy, works by binding to the somatostatin receptors, and these somatostatin receptors are on the cells of carcinoid tumor mostly, okay? But they're on other cells as well, but majority of them, they saturate the surface of carcinoid tumor, okay? Okay, this is a picture. You're going to have to memorize all of that name in there. No, I'm just kidding. This is a picture, a simple example of, this is human somatostatin. That's normal somatostatin that's normally made. Now, this formulation of it, the normal natural product, doesn't last in the system very well. It gets degraded, eaten up by enzyme breakdown. So to be a therapeutic modality or a drug agent, you have to have it last in the system longer. So that's why it's been modified in the form of Octreotide and Lanreotide. And the reason is that this is highlighted, this is a crucial part that binds to the receptor. So the reason these drugs belong to the same class is because these receptor and amino acid remain the same. Because they are not in the same class if they're not going to bind to the same receptor. Do you see what I'm trying to say? They wouldn't be called somatostatin analog if they don't bind to somatostatin receptor. But the drug itself, both of them are slightly different because of the other amino acid that's there. So they're not exactly the same drug, okay? Okay, so what is the efficacy of these drugs in being used to control carcinoid syndrome? You've seen this. I'm probably, if I didn't show it, multiple people have shown it all through the whole time that you're here. But what I want to point out is that these drugs has been studied decades ago. I used to say decades older than me, but now I'm starting to say, no, I think around the time that I was adult enough to understand. Because I actually am grateful that you didn't mention all where I am and what I do, because that would just date me on how old I am. So that destroyed the purpose of dyeing your hair. But the efficacy of controlling carcinoid syndrome, or the ability or its effectiveness in controlling carcinoid syndrome, is listed here. But I highlight that way back in the 1980s and also in the 1990s, both Octreotide and Lanreotide has been evaluated in its ability to control symptoms, okay? And they're fairly robust. And I just want to show you that these are old compounds. They're not brand new. But it's only recent discovery of its being an anti-tumor treatment that it becomes new, but it's actually not new. And the activity there is listed as robust, okay? The other things to know is that you guys always wonder, is that the same? Now, you know about these two drugs as far as controlling tumor. Are they effective in controlling symptoms? Well, there's never going to be a robust big enough study to compare efficacy of controlling symptoms between these two drugs. The reason is, and the very nature of it is, number one, there's no reason to it when there's already indicated and people can pick and choose. The second is one dose does not equal the other agent. One dose in Lanreotide does not equal the other one, okay? So there won't be a study like that. But there was something in attempt to figure out if there's equal efficacy between these two drugs to control symptoms. And actually they show pretty similar, okay? But I have to say it's a very small study and it's very variable on the dosage they use. All I can say is that as a drug, both of these work on the same receptor, therefore the symptoms control are fairly similar as far as symptoms control. And I list the contrast and comparison, but not to show you one is better than the other, but here's the difference. The doses that exist in Octreotide has been 10, 20, and 30 for symptoms control. Lanreotide does have dosage that comes in 60, 90, and 120, but in the US, it's only available at 120 for tumor control. So that's why you don't see the 60 or 90. The two drug is also different in the sense that 10 milligram of Octreotide does not equal 60 milligram of Lanreotide, so therefore you can't compare. So whenever you switch from one or the other, you need a experienced expert or experienced person who decipher clinical trials or evidence of it to try to apply to you. And then the other thing to know is that both drugs works differently or deliver differently. Octreotide by IM, and if you guys are sitting down, some of you may already feel the effect or have all that experience. And Lanreotide is subcutaneous. So their mechanism of delivery is different. The other thing is that the way they were assessed for tumor control was also different. Octreotide was evaluated in PROMED to determine if it has anti-tumor effect, meaning the ability to control tumor from growing in mid-gut neuroendocrine tumor at a single dose of 30 milligram. And Lanreotide was evaluated for its anti-tumor activity in a broader group of neuroendocrine tumor, meaning GI tract and pancreas, at a single dose of 120 milligram. I'm not going over those studies, but to say that in PROMED, it's demonstrated that Octreotide can prolong time to tumor progression compared to placebo, meaning no treatment, for mid-gut neuroendocrine tumor. And in the Clarinet study, Lanreotide was able to demonstrate among treating patients with GEP-NET or gastrointestinal pancreatic neuroendocrine tumor, time to tumor progression and death was actually reduced by being on Lanreotide at a single dose of 120 milligram. So what's the take home on somatostatin? It's the first-line therapy for control of symptoms of carcinoid syndrome. There are now adequate evidence to support somatostatin analog to be a highly effective for control of symptoms of carcinoid syndrome. Notice I'm not discriminating which one as far as symptoms control here. They're both, to me, are adequately controlling symptoms, but they also now effective data, there are enough evidence to support that both of them are effective for anti-tumor control, but in very different setting, patient population, and whether they progress or treatment naive, okay? So let's talk about management of refractory symptoms. That's the more interesting one, okay? There's a whole slew of things in here that has been used to manage symptoms of carcinoid syndrome that has been refractory to somatostatin analog, okay? I'm gonna concentrate on 3. And I'm not going over details, but to 3. But among those 3, the one that I think is the most interesting and not actually most promising and most readily available and supported by level 1, a prospective study in a randomized group directly assessing its efficacy in managing symptoms of carcinoid syndrome that has been refractory to somatostatin analog. All of the other one there has never been assessed. So the benefit or the efficacy of these other modality in controlling refractory symptoms are assessed indirectly. So except tryptophan hydroxylase inhibitor, the drug of choice that we're going to talk, or the drug that we will talk about, okay? So I'm going to concentrate on those 3. I'm not going to talk about systemic therapy because every time I'm up on the podium, everybody asks me to talk about chemotherapy or systemic therapy. It's boring, right? So we need to change that up. And then I think I will leave it up to my surgical colleague to talk about debulking surgery. And additional somatostatin analog, that's another one. It's also depend on regional on what you believe. But it is used when symptoms are refractory to to the standard dose. There are ways of increasing the dose, but you have to select patient carefully. Okay, so we're not going to talk about those. We're going to concentrate on these three. Let's say liver-directed therapy. This morning, you heard a beautiful presentation on what is liver-directed therapy is about. I think this directed therapy to the liver is one way of managing refractory symptoms. There is no prospective randomized study to see if this is better than placebo control. But the nice thing about it is it's minimally invasive and it makes sense. It's based on the theory that there are two blood supply to the liver, okay? You see I can't see that far, see this is dating me. So the normal liver is supplied by the blue vein, but the tumor is supplied by the red artery. So if you manipulate or just utilize the artery, you will find or target mainly tumor. So you have the ability to select out which liver portion you want to treat, what tumors you want to treat, provided you can find a map or vessels that supply to that area. But it's selective, or it could be comprehensive, but it's mainly treating the liver, okay? And it's minimally invasive, and I mean, it's an outpatient procedure. And so there have been various ways of administering things into the liver or the tumor in the liver. You can do it by bland, either a microsphere that has no activity but block blood supply, or alcohol to block blood supply, or actually introducing toxic agent, a radioactive beads or chemo to kill the tumors. The goals here is that you reduce the cancerous cell that is actively producing hormone, so you can reduce the symptoms, okay? Or you reduce the blood flow or deliver toxic agent to the tumor to kill the tumor, to shrink it down. Okay, so tumor control and symptoms control, that's the goal of therapy with liver-directed therapy. I think that liver-directed therapy can be very effective in reducing symptoms of carcinoid syndrome, even in the absence of significant tumor shrinkage. So if you shrink very little in the tumor, you can still have some noticeable or actually moderate to significant symptoms control. The use and benefit are limited to patients with only liver metastasis, and the treatment is because the treatment is directed only to the liver. Patient selection is key. Provider selection is key. Their experience, how much have they done, and do they understand about neuroendocrine tumor are key. And if you don't know, you can ask an opinionated oncologist like me, and I can tell you. I'm very free with advices. But let's talk about peptide receptor radiolabel radiotherapy, PRRT, okay? This is not to rehash what you already know about yesterday, but how does it apply in controlling carcinoid syndrome? There's no data on it in controlling carcinoid syndrome that has been refractory. But here's the interesting outcome. Peptide radiolabel radiotherapy, or PRRT, is based on delivering this peptide conjugate directly to the tumor, and it's based on this cartoon. It's actually multiple of these peptides, so this is a huge, big-sized version of this peptide, okay? So I'm going to show you. So this is for any peptide. It doesn't have to be net, okay? So this is the warhead here. That's the radioactive material, the radiation. This warhead is actually not only just a warhead, but it's also a signaling thing. So wherever it's light up, it's sort of like the tail end, and you can see where the drug or the therapy is being delivered, or the radioactive material is being delivered. This is the other key. This is the target. If this key doesn't fit to your tumor where you need it to go, it won't go there. It can go anywhere in the body, therefore you have more toxicity. So in neuroendocrine tumor treatment with PRRT, the peptide looks like this. The warhead has typically a diagnostic component, the one that flare up to tell you where this peptide is being delivered to, typically has indium or gallium, and then the nuclear warhead is usually lutetium or yttrium. Okay, those are radioactive material that can be hot enough to kill the tumor. And then the peptide, because this is neuroendocrine tumor, are typically somatostatin analog, okay? It could be an analog, it could be an antagonist or an agonist, either way, but it has to send this nuclear warhead to the place that you need to be. In neuroendocrine tumor, it's those receptor for somatostatin. So that's why this is important, okay? But why am I rehashing this that's been talked about yesterday? This is the study, the only study and prospective randomized study that demonstrate there is a benefit of PRRT definitively over Sandostatin or Octreotide at 60 milligram in mid-gut neuroendocrine tumor. And the result is this. It's been presented, it's been broadcast everywhere. But the reason I'm pointing out is not that it has the ability to reduce the disease progression or death by 79%. But what I want to point out is it's very rare to find an agent that can reduce tumor that is midgut, neuroendocrine tumor of the midgut or carcinoid tumor rarely respond to anything. With PRRT, the chance of doing that is 19%. With Sandostatin or Octreotide LAR at 60 milligram, it's reduced at 3%. That's what we know. I've always tell my patient with any somatostatin analog, it can control your disease, but for you to expect significant tumor shrinkage, it's not likely to happen. But this here lies the, this here lies the ability to have tumor shrinkage, and if more tumor cells are dying, then it can't produce hormones to produce symptoms. So that is another way that I think is novel, and that's something that we explore on controlling symptoms of carcinoid syndrome that is refractory to Sandostatin, okay? So this is an ideal, optimal outcomes. I mean, you always want to show good story, but this is before PRRT, this is after, so smaller, smaller, smaller. But this is harder to see. With before and after, it's supposed to be with each cycle, the intensity or the lesion of the tumor should be less and less, okay? Okay, so let's shift gear and talk about the one agent that actually have prospective study that demonstrate its effectiveness in controlling refractory symptoms of carcinoid syndrome. It is from a class of drug called tryptophan hydroxylase inhibitors. Okay, what the heck is tryptophan hydroxylase inhibitor? Okay, remember carcinoid syndrome are mediated predominantly by serotonin. So if we can somehow manipulate the serotonin mechanism or reduce its synthesis, we may be able to manipulate or control symptoms of carcinoid syndrome. And that's this. This is a cartoon of a carcinoid tumor and how serotonin is made. Tryptophan in the cells here are hydrolyzed or going through tryptophan hydroxylase to be converted to serotonin, which is secreted and then ultimately filter and going to the urine to become 5-HIA. So if you have a lot of serotonin in the body, 5-HIA will be elevated. That's how you know you have neuroendocrine tumor. That's one of the biomarkers that your oncologist or physician follow when you are treatment for neuroendocrine tumor or carcinoid symptoms. This tryptophan hydroxylase is actually the rate-limiting enzyme in serotonin biosynthesis. By blocking this, you're going to block the abnormal production of serotonin, okay? So therefore, you will effectively reduce the hormones and peptide responsible for the symptoms of carcinoid syndrome. That is the theory, right? Is there such a drug out there yet? Well, that's exactly what there is. Telotristat, I never pronounce this right, just like, what is that? Somatuline. I never figure out, if you're in the South, it's Somatuline, and if I'm in the North, it's Somatuline. So it's tomato, whatever, but it's actually an important compound. Telotristat is actually a tryptophan hydroxylase inhibitor that has been developed as an oral compound. It's oral. That's lovely for anybody who has been 30 years, 15 years of getting injection. This is oral agent, okay? It's actually blocked this tryptophan hydroxylase enzyme, and it has been evaluated in a randomized prospective study for its efficacy in the very question that we're asking, in the management of refractory symptoms of carcinoid syndrome. And it's the result that currently, the study is done too, and the results are being reviewed at the FDA. So hopefully soon, this year or whenever, I never can predict when the FDA will make its mind or what's going to happen, but soon, it's in the work for indication, hopefully for the management of refractory carcinoid syndrome. Okay? It is based on this study, TELESTAR. TELESTAR was designed to evaluate the efficacy of Telotristat in refractory carcinoid syndrome. It has 3 arms listed here, placebo arm. It's always painful to say that there is a placebo arm. That means no treatment. But unfortunately, to assess the true benefit of a drug, you need to have a placebo arm. You have a placebo arm and 2 doses of Telotristat, okay? And the primary endpoint within that 12 weeks of randomization is the number of bowel movement decreased from baseline. And then after 12 weeks, patients are randomized, unblinded, not randomized, unblind, and cross over and get the actual drug, okay? Okay, so here's the result. The results show that Telotristat effectively reduced daily bowel movement frequency in patients with refractory carcinoid syndrome. But I'm going to show you this. With best support or placebo, just doing everything you can except actually getting the actual drugs, the ability to reduce bowel movement from baseline, being constantly watched by your doctors, try this, try that, is only 20%. I know I'm being late. And then 40%, okay, it's making a noise. So 40% with the drugs, both at 250 and 500 milligram TID. So this is statistically significant, but to me, it is clinically significant because if you can reduce your bowel movement that has been refractory to Sandostatin or Lanreotide or Somatostatin analog by almost 50%, your quality of life would be significantly improved, especially with a pill, okay? Okay, so but even more proof of concept is this. When they took the patient off the study and they unblind them, if they're on placebo, they get the drug. But you can see when they are on placebo, the bowel movement frequency is this much. But when they're on the drug, it's dramatic drop down. It's a proof of concept that this is a therapeutic benefit that is real. Furthermore, if they were on the drug and continue to be on the drug, there's sustained benefit on it. So the bowel movement control is also sustained when they are off the protocol that is randomized. So you can see that it's also sustained benefit. Okay, so the side effect, just to point out, it's actually very, very manageable. I know you guys are looking at all of this, but the key is this. Whether you're on placebo arm, 250 or 500, or even the open label therapy, the side effect is actually can be explained both in the placebo. Actually, sometimes there is a lot of side effect. Any side effect is noted on the placebo. I think majority of the time, these symptoms or these side effects are so vague that it can be on both arms. So it's not contributing to the drug itself. All drug has side effect, but it's not significant and it's manageable. So the takeaway message on the TELESTAR is this. Telotristat is able to reduce bowel movement frequency, and that is actually statistically significant, and to me, clinically significant over placebo. It has a favorable safety profile, and it's oral pills. So to me, it represents a potentially new and, again, oral treatment approach for patients with refractory carcinoid syndrome. So we've learned about clinical presentation of neuroendocrine tumor, functional neuroendocrine tumor, carcinoid syndrome, management, and what is the takeaway message? The takeaway message is this: listen to Dr. Phan's recommendation all the time. No, I'm just kidding. These are the takeaway message, but you know them already, okay? That's it, thank you. I'm sorry I went overboard. I thought I would talk a lot faster, but apparently I did not have enough coffee.